on it. Their dosing is only at bedtime. It's really just a sleeper. It's not for psychosis or anxiety, depression, whatever. So anyway, was it started for a good reason? And then finally, is the cost defensible? And I only put one example. There are a lot of examples, but Rexulti got approved for dementia with behaviors. Uh, but if you actually look through, and we're going to do this maybe down the road here in the next few months, if you look through the actual data, it's no better, and it might not even be as good as risperidone or Zyprexa, which suffer from having asked for this 20 years ago when the FDA was less likely to approve things. But it's much more expensive, like factor of, I don't know, 50. I don't know. So cost does matter. Okay. One of the things that I would highly recommend, if you, I'll show this to you when we quit sharing, but this is a picture of a AGS, American Geriatric Society, fold out, laminated pocket version of the Beers criteria. I carry this around with me. If you ever wonder, you can look things up quickly. You can actually go online. You can Google Beers list and it come up, and you can download a PDF version of it and look things up. And it gives you reasons why things are unnecessary. All right, with all that said, let's get right to it. And I'm going to try to cover a number of things. So aspirin, I told you we'd talk about that first. So getting rid of aspirin for primary instead of secondary prevention. The guidelines for this changed in 2019 to show in persons who had not previously had an MI or stroke, low-dose aspirin was more likely to lead to major hemorrhaging and death than it was to prevent an MI or CBA. And it wasn't close. It's interesting with diabetes, it was close. Couldn't tell them apart. Outcomes were the same, but without diabetes, which to me says don't use it because you didn't improve care. But outside of that, it's just it wasn't anywhere close. That information was widely disseminated, but by 2021, the last time I saw this in print, almost 30% of Americans over age 60 were still using aspirin for primary prevention, which at the time was 18,500,000 people inappropriately taking it. Now, of that, there were about 3 million that were taking it without their provider's knowledge. But that still means there were 50,500,000, give or take, people in this country that the provider said, yeah, go take aspirin. So, and by the way, I'm putting the references here, and I think you'll have access to these later, or you can always reach out to me and I'll send references to you. But a lot of people getting it that shouldn't. And we still see it in long-term care. As I review charts, I probably send this recommendation, get rid of aspirin, probably 25 or 30 times a month. So easy one to get rid of, and getting rid of it, you'll just be following the guidelines. Okay, number 2, vitamins. Not a real dangerous one, but lots of people on them. So here we go, back to the United States Preventive Services Task Force. In 2022, they updated the guideline, said vitamin mineral supplementation was associated with little or no benefit in preventing cancer, cardiovascular disease, or death. Beta carotene increased your risk for lung cancer. There was some limited evidence that some supplements could be associated with a higher risk of harms like hip fracture with vitamin A, or hemorrhagic stroke with vitamin E. And here's the reference on it, JAMA, for that. But beyond that, there's this wonderful study, the Iowa Women's Health Study, published almost 10 years ago now with this data. They followed 39,000 women, all in Iowa, for 19 years. So anybody that knows anything about statistics, that's a huge power. I mean, that means it's really easy to find things that are statistically significant. They did multivariate models, use of multivitamins. The hazard ratio was 1.06, confidence interval greater than 1, showed that it increased your risk of total mortality compared with women who didn't use supplements. So, I mean, we don't have to get everybody to stop, but we should at least be educating that if you're taking these, it's not huge, but your risk of mortality is significantly increased versus not taking it. That's a hard thing for people to accept because most of the people in this population grew up on Flintstones vitamins and 1 a day and Geritol and all that kind of stuff. Within the study, the same study, they found, I'm just going to throw these out here, these 6 individual components that all by themselves, taken separately, increased risk. The worst of them was copper. I don't know anybody, by the way, I don't know anybody that takes copper supplements, but I'm sure there are some. But a lot of people taking zinc, magnesium, iron, folate, B6. And yet if you take them and you're not deficient, I mean, look at this, 10 to 15% increased risk of death. Calcium was the only one. It was inversely related. The women that took calcium, and it's probably, if they regularly took calcium, probably had fewer fractures, fewer hip fractures, DVTs, PEs. And if you follow 39,000 women for almost 20 years, you could pick that up. Okay, so number 2, get rid of vitamins. Vitamin D, if you're giving it every day, there's nothing wrong with that. It just is 30 pills a month. And you can give that in 1 or 2 pills a month. I was part of the original studies. It was part of the multi-group study looking at this way back in the early 2000s. And we found that 50,000 units once or twice a month was equivalent to giving it every day, the same dose every day. The most important thing in this is you got to give it with a fatty meal, and we forget that way too often. It's A, D, E, and K, the 4 fat-soluble vitamins. If you don't take them with fat, you don't secrete bile. You don't secrete bile, you don't absorb the vitamin. So it's a waste of time to give it. So that would be the most important thing, is make sure they get it with a fatty meal. And if you do this just twice a month, you're saving 28 pills a month. But it's not just the pills and the minimal cost, it's the nursing time to just hand out that many more pills. And then if somebody at some point wants to talk about how come recent data doesn't show that vitamin D helps, we can talk about that. It has to do with the way that granting has evolved over the past 2 decades, so that right now there's not a lot of focus on making sure people get it with a fatty meal. There's not pre and post study levels to see if they were insufficient is less than 30, deficient is less than 10. And if you just enroll the general population, not everybody's insufficient, so there's not going to be room for improvement. Anyway, simple thing to do just to decrease pills, give it twice a month instead of every day. Okay, next.
Dr. Gahm, what are you
go ahead.
What are you finding to be the fattiest meal of the day? Is it breakfast? Because
well, I leave,
or
yeah, I leave. So when I write the order, I just say with the fattiest meal of the day. And sometimes the facilities will say, well, that's breakfast for us, because everybody's getting bacon and sausage and they almost all eat it. And others say, oh, noon is the meal where people eat the most. So I don't get in the way of that. I let them pick what they think, not only what meal has the most fat, but which one do people in your facility like the most or eat the most. Yeah, I don't know. Other than that. Okay, next one. See this all the time. So Remeron or Megace for weight loss. So John Morley wrote a wonderful article about 20 years ago that showed that weight loss, cachexia, or protein calorie malnutrition common in long-term care, and depending on the study, anywhere from 5 to 65% of people. And this is, if you're interested in what I'm telling you, the next two slides, this is just let me know. I can send this to you so you don't have to look it up. It's a really nice study because it was actually done in long-term care facilities, which we see very little of. So look at Megace first. So Megace is only approved for AIDS, wasting disease, some cancers. It's not approved for seniors with weight loss. Well, okay, so it's not. Um, Using it is associated with higher mortality, even if you use it for approved indications. And the higher mortality isn't, well, they were sick and they were going to die anyway. This is when part of the study where it was blinded. And so placebo or Megace, the ones on Megace, had a significantly higher mortality rate. It acts as a partial steroid agonist, can lead to adrenal suppression. Um, in men, it decreases testosterone, leading to muscle loss, which is exactly what you don't want. And it's associated with an increased risk of DVT and thrombotic events in men. All right, so what about Remeron? We see that all the time still. It's an antidepressant, antagonizes serotonin and histamine H1 receptors. And I noticed Dave Shepard is on the call. And Dave, jump right in since you did such a wonderful job on Tuesday talking about histamine and antihistamines. If you have any comments, feel free to jump right in. There is no literature, and I underlined that and bolded it, just so that you're aware. My number one rule for what's unnecessary is there evidence to support it? Well, here it is. There is no literature to suggest it leads to weight gain in the absence of depression. All right, so what if you are depressed? Well, if you're depressed and you use it successfully to treat depression and their depression improves, 12% of people will gain weight. So 1 in 8 chance if you're using it for depression, but just to use it for a weight gain agent doesn't work. If you get to higher doses, you get up to the 37.5, the 45 milligram a day dose, that higher level of serotonin is more likely to lead to cachexia as you increase the CNS levels and you have early satiety. So you kind of go through this bell curve and you pass the top of the curve and you get to a point where you're suppressing weight gain. If you add it to other SSRIs or SNRIs, the FDA has a special warning for Remeron. The risk of serotonin syndrome may increase if you use it in combination with other agents. And by the way, this isn't on every antidepressant in the FDA language. So you should take that into account when prescribing it for appetite stimulation with other agents. Okay, and I think a couple more, and then we'll call it quits and open it up for discussion. So Seroquel, of the commonly used antipsychotics, it is the least potent. There's a wonderful article about a year ago in the psych literature that looked at European, where they have all these wonderful databases, and they looked at hundreds of thousands of people with schizophrenia and schizoaffective disorder, and what was their response to which antipsychotics worked best and lasted longest. ClearDown prioritized like 45 of them. And maybe not surprisingly, number one on the list was the Q3 month in Vega, one shot, $8,000. And it worked best. But they drew a really sharp line at the bottom of the list. There was only one drug that they considered not effective and shouldn't be used in the European literature. And it stood out as being the least valuable. And here it is. It was Seroquel. Least potent. It is metabolic. So along with things like Zyprexa, Lunesta, Clozaril, you'd like to avoid it in diabetics. It's going to make their diabetes worse. It's really short half-life, requires you to give it 2 to 3 times a day. And with that, you're going to see ups and downs, meaning that they're going to be sedated and then awake and out of control and then sedated and wake, out of control. Your brain, like seizure drugs, Your brain likes things at a nice, steady state and without any change. If you give it only at bedtime, CMS and now surveyors, and we've seen this in several surveys already, it's considered a chemical restraint. It's not considered an antipsychotic. So the Seroquel bedtime, time to just put that away in the closet, quit using it. Okay, another one of my pet peeves, those of you that know me for very long, Neurontin. If you only want to read one reference, this one right here, I'll email this to anybody willing to read it. It's only 2 pages. It's an editorial, so it's really easy to read. There's not a lot of scientific detail and tables and charts. It's really simple and tells the story of how Neurontin got started to be, for use in neuropathy. It's not approved for neuropathy, except for trigeminal neuralgia. It wasn't more effective than placebo in the trials the company conducted to try to get it approved for neuropathy. It has lots of potential side effects: depression, edema, falls, dizziness, respiratory depression, death, increased infections, nausea, tremor, others. The company has been sued since 2006, 3 times by the federal government for mismarketing it for neuropathy. And the sum total over those 3 times, they've settled all 3. They didn't take any of them to trial, but they've paid just barely under $1 billion in settlements for mismarketing it. And they don't deny it. Mismarketing it for neuropathic pain. And as part of the settlement, they also agree not to continue to mismarket it for neuropathy, but they make so much money with this drug, they keep doing it anyway. They don't even contend that it's good for pain, but we're so deep into the opiate crisis, I see over and over people trying to use it for pain, not just for neuropathy. If you use it with opiates, benzodiazepines, or muscle relaxants, there's a box warning. It significantly increases risk for respiratory depression and death. And if you're going to misuse this drug, make sure that you explicitly talk about this, tell patients about it, and let them know it's not like the vitamin thing where it's a 5% increased risk. It's if you take the opiate course that's required now for your DEA, you find out, put 2 of these together, the risk goes up about 6 times, 3 of them together about 15 times. Use all 4 classes of drugs, it's about 30 times the risk. It's a big risk. Okay, last one we'll talk about today, Depakote does not work for behaviors associated with dementia. That's part of this first reference down here. If you look it up in up-to-date, this is where it starts. This updated review corroborates earlier findings that valproate preparations are ineffective in treating agitation among demented patients. Valproate therapy is associated with an unacceptable rate of adverse effects. Don't use it. This second one from neurology shows that it accelerates brain atrophy. It has many serious unrecognized adverse effects. Here are the 3 that I follow most closely. Increases ammonia, which leads to encephalopathy. If the ammonia is up and you're encephalopathic and they start acting psychotic, one of the things you can't do is treat it with antipsychotics. They don't work. It's like trying to put a grease fire out with water. It just doesn't work. Doesn't matter how much you use, how many agents you use, it just doesn't work. The only thing that works is stopping the Depakote. You can get dangerous thrombocytopenia. I've seen levels as low as 4,000 or 5,000 people bleeding. Hyponatremia, common with lots of things, but Depakote. It's not approved or effective for schizophrenia, but I see people trying it all the time because it's a psych drug. And then for seizures, I see people trying to use it for seizures. Well, if you're old enough, you were taught at a time when you had to learn the 10 different types of seizures. And of the 10 different types, this only treats 2 of them. It's only approved for absence and partial seizures. It doesn't work for tonic-clonic or the other 7 seizure varieties. So just trying to say, well, it's a seizure drug. And the neurologist ordered it. Those of you that know Ron Kramer, who used to be with Rocky Mountain Senior Care, will know that he used to talk about this. How come a neurologist would do that? And his answer was that since the mid 90s, we've spent so much time teaching neurology fellows how to read a PET scan, an MRI, a CT, an EMG, an EEG, and all this other stuff. They don't have time for the basics. So he said, he was an epileptologist. He said, we barely teach them about seizures. So they do the same thing the primary care doc would do, which is, well, it's a seizure drug, let's add it. So, all right, there it is. That's the quick run through my 7 drugs that you can deprescribe often and quickly. Question? Discussion?
Hey, Greg, it's Travis. I think,
Yeah, Trav.
I just wanted to add that one thing that helps me with the reductions, and which is more of an art than it is a science, is basically getting the patient's goals, doing some, joint decision making, and oftentimes, if you can go over them individually and do some risk benefit, you can eliminate simply based on their priorities, especially the folks in the 90s. So that's been sort of where to start when I'm talking to, the older patients.
Yeah. And it's really hard for them to give up on things like vitamins and things that, old Doc Wilson put me on these years ago, told me never to stop. So it's hard to get through a lot of that.
Yeah, hey Greg, this is Dave Shepard. The mirtazapine discussion in facilities for weight gain is something that happens a lot, and I have trouble kind of navigating that. And sometimes you'll try it because families want to try it, but I guess I usually go 30 days, and if you don't see any response, I try to peel it away. Is there any guidance on anything like that?
Well, I can send it out to you, but I put the reference in from Pharmacology, was the journal from 2014, where they actually looked at all these patients in a blinded fashion. And, that's where they came up with the statistics. It just doesn't work. Um, but, I also in somewhere around 2017 did at the CMDA conference, joint led a presentation on placebos with Don Murphy. There's a lot of placebo effect, and if people are taking a drug that somebody told them is going to help them gain weight, they start believing it, or, it's going to make your pain go away, they start believing it. There's a lot to placebo, but it's not that safe, a placebo. If you're going to use a placebo, use a vitamin or something that has very little chance of causing harm. So yeah, I bring the article in. I say, well, here's the data. They looked at this head to head, blinded. Nobody knew what they were getting, and it just didn't work. And
Okay.
A lot more side effects in the group that got the drug than the group that got the placebo.
Thank you.
I appreciate Travis's comment about getting those goals of care for patients, and how difficult the conversation can be. I like an article from Dr. Green et al. About patient preferred language for deprescribing. And they just tested some common phrases that people use and ranked them from what patients like to hear the best and worst. And sometimes I like to just say them out loud, so I'm knowing what to say at the bedside.
That's great advice.
Yes, hi, I'm Lena, consultant pharmacist with Enzyme, and I've been asked by a provider that if they choose to use mirtazapine for appetite stimulant, if we still need to review them in Sec Pharm, and if they follow the same GDR schedule as any other psychotropic.
Well, yeah. So actually, since October 22nd, I think of 2022, any drug that is CNS active has to be reviewed by your psych pharm committee. Unlike the other drugs, they didn't put a time frame on it, quarterly, whatever, but the implication is annually. So anybody that's on antihistamines or, Remeron for weight gain, whatever, would have to go through there at some point. And part of it depends on where they're working. If you're working in a Vivid Beacon facility, you won't get to use that, because if I see it, I'll stop it. We make that a corporate policy. And in my other buildings, and Chris, you can read it, feel free to jump in too, but in my facilities, there are a number of things we just don't do. And that's one of them, Remeron for weight gain.
Thank you very much.
On that note, this is Dave again. Dronabinol I think it's been looked at in HIV-related cachexia and stuff like that. But to my knowledge, there's no good data for weight gain in our setting using that either. Is that correct?
That is correct. Okay. We've reached our half hour. If anybody wants any of the references, let me know, and I'll be glad to send them out. And we'll go from here next time we meet. Thanks, everybody.
Thanks, Greg.
Yeah, thank you.